Hi, it's Caitlin, and I want to be talking about a case study today, a case of neurocardiogenic syncope, or NCS. So I'm just going to be hitting the main points here. Allison Jacobson, in the past few weeks leading to final exams, she was feeling frequent headaches, and she felt like her heart was missing a beat. She fainted not once but twice, and while waiting in line, and she decided to see the family physician. No abnormalities were found, and the physician decided to order a head-up, tilt, or HUT test. So some background information here. Syncope is actually fainting. It's very common. Accounts for about 6% of hospital admissions each year. There's a group of fainting disorders, which includes neurocardiogenic syncope, which is NCS. It is caused by a drop in arterial blood pressure, which is shortly followed by a slow heart rate. Dysautonomia is a group of medical conditions that are caused by problems in one's autonomic nervous system. If the ANS is not working the way it needs to, it can cause blood pressure and heart problems. So some presyncopal warnings that happen prior to fainting includes dizziness, warmth, vision disturbances, nausea, vomiting, and of course the actual fainting or the sudden loss of consciousness. So ECGs can be used during initial presentation post-syncope to exclude neurologic and cardiac causes. But when physical exams and patient history cannot give enough information about the cause of the syncope or the fainting, a head-up tilt test can be used to diagnose NCS. In this test, heart rate and blood pressure are recorded minute by minute while the patient's head is in a head-up position and while the table is slowly tilting at different levels. You can see this here in this diagram. So there are a few types of treatment of NCS. A patient could increase their dietary salt and fluid intake, but from a pharmacological standpoint, to prevent and manage NCS, beta-adrenergic receptors and selective serotonin reuptake inhibitors can be used. We've seen these in past clinical applications. So the beta blockers can be administered through an IV or orally and may inhibit myocardial contractility, which is important, and we'll see that in a few slides. SSRIs can be a beneficial treatment because serotonin has been thought to inhibit sympathetic neural outflow. So I'm not going to go into too much detail about systemic blood pressure. I will kind of just go over a summary of that and cardiodynamics. So the most important equation here is blood pressure equals cardiac output times total peripheral resistance. Cardiac output is dependent on stroke volume, and there are three factors that contribute to stroke volume, which includes preload, sympathetic stimulation, and afterload. We can see here the arrows will indicate if one increases, then how stroke volume will react, and we can also see how the total peripheral resistance has three factors that contribute to it: blood viscosity, total blood vessel length, and blood vessel radius. This is seen here in this equation. R equals 8 times L times N all over pi times r to the fourth power. So if cardiac output increases and TPR is maintained, the blood pressure can increase. So the Frank-Starling mechanism of the heart just describes the relationship between end diastolic volume and stroke volume. So if EDV increases, there's an increased stretch of cardiac muscles. This increased stretch actually leads to an increased force of contraction, unlike in skeletal muscle cells. And this leads to increased stroke volume, which eventually leads to increased blood pressure. And that can be seen in the last slide of the summary. So the autonomic nervous system on cardiac activity. So we learned that sympathetic stimulation and parasympathetic stimulation can increase or decrease the heart. So sympathetic is known to increase the heart rate because it opens the funny type sodium channels faster, and these funny type sodium channels actually create the pace of the heart beating. The parasympathetic stimulation will decrease heart rate by opening these funny type sodium channels slower. So the sympathetic stimulation can also increase contractility, which increases stroke volume because there's more calcium coming in during the action potential of a contractile cell. The contractile cells, as we all know, are the 99% cells. So if there's more calcium, the ventricles will have to squeeze down more forcefully and thus have an increase in contractility. So note that the parasympathetic nervous system does not play a role in action potentials of contractile cells because the parasympathetic only communicates to the conduction cells, which is the 1%, which is primarily communicates with the SA node in the right atrium and not to the contractile cells of the ventricles. So the baroreceptor reflex. So they are sensory receptors that sense the arterial pressure in the body. They can fire a different frequency of action potentials in response to the stimulus, which is either high or low blood pressure. For example, if the stimulus is high blood pressure, the baroreceptor will fire action potentials at a high frequency, and the control center, or the medulla oblongata cardiovascular centers, will use autonomic motor neurons to command the effector. The effector is the heart, that is what is responding. So this firing of high frequency action potentials will decrease sympathetic action potentials and increase parasympathetic action potentials, which ultimately decreases heart rate. So how does this all come together? So we can kind of see how the overall picture of neurocardiogenic syncope and how the patient Allison is feeling. It's an imbalance between the nervous system and the cardiovascular system. The preload state is low in the patient because of venous pooling that is happening in the lower part of the body, which leads to a decreased blood supply in the upper part of the body, importantly, the heart and the brain. So the body's homeostatic mechanism wants to make up for this lack of blood by decreasing the radius or vasoconstriction, which will increase heart rate and eventually increase cardiac output. But those with neurocardiogenic syncope, this homeostatic mechanism does not work the way it needs to. So instead, sympathetic stimulation will occur and cause ventricular contraction. This ventricular contraction will also end up in low end systolic volume incorrectly, and it tells the brain that the blood pressure is high because of the dysautonomia, the dysfunction of the ANS. So sympathetic activity will decrease, parasympathetic activity will increase. We all know that this is the rest and digest nervous system, and it will have vasodilation or relaxing of the arteries, which ultimately lowers blood pressure. This leads to a decreased oxygen supply to the brain, which leads to the fainting or syncope in the patient.